Good morning, students. Today, your class assigned is a very important topic, that is anemia in pregnancy. And this is a topic which is very important both from your theory point of view as well as from your practical point of view in obstetrics and gynecology. So in this class, we will be covering the definition, prevalence, physiological changes in pregnancy, classification of anemia, iron metabolism, clinical features, and effects on the mother and the fetus. We'll be dealing about the investigations of anemia and briefly about the management. So by definition, the anemia term is derived from the Greek word anaemia, meaning lack of blood, that is without blood. So what it actually means is it is a condition in which the number of red blood cells or their oxygen carrying capacity is insufficient to meet the physiologic needs, and this varies for age, sex, altitude, and pregnancy status. So in pregnancy, how do we define, what are the cutoffs that we take for defining it as anemia in pregnancy? There are basically two definitions that you must know. One is by the WHO, which defines anemia as hemoglobin less than 11 gram% or hematocrit less than 33%, irrespective of the period of gestation, while the CDC defines it as hemoglobin less than 11 gram% in the first and the third trimester, and less than 10.5 gram per deciliter in the second trimester. Why is it so? Why they have taken the cutoff slightly lower in the second trimester? We will understand it when we read about the physiological changes of pregnancy in the cardiovascular system. So briefly, firstly, to divide or classify anemia, there are various classifications that are used, but broadly they can be classified as mild, moderate, and severe. When it is less than 10.9 but more than 9, we classify it as mild anemia. If it is less than 7, it is severe, and in between, it is moderate anemia. But there is another classification by the Indian Council of Medical Research, which classifies it into 4 categories, that is mild, moderate, severe, and very severe. See here, it is the same, severity is less than 4 when it is less than 7, and when it is less than 4, it is very severe. But there is a slight difference in the mild and moderate. In the mild, the upper cutoff was taken as 9 in the previous classification, while in this one we take as 10 to 10.9, and for moderate we take as 7 to 10. So these are the basically categories of anemia according to the levels of hemoglobin. So how common is anemia? Why do we need to understand, or we need to study about anemia? Is because it is a major public health burden affecting nearly 2 billion of the world's population. Of all anemia in pregnancy, 75%, that is 3/4, is due to iron deficiency. And iron deficiency in anemia in pregnancy affects 50% of the pregnant women worldwide. So you see the chunk is very big, and more so in developing countries. It is around 56%, ranging more in the lesser developed countries. It is as high as 75%. So if we see the scenario of Nepal, which is a less developed country, in our context, we see that there is an overall anemia prevalence of 68% among women. And among pregnant women, it was even higher. It was 75%. So most of the patients that we see are anemic. In other words, 3 out of 4 pregnant women in Nepal are anemic. So I told you in the earlier slide that we take the value or cutoff as slightly less in the second trimester, that is less than 10.5 in the second trimester and less than 11 in the first and third trimester. Why is it so? Is because of the physiological changes that began to be more pronounced, especially at the early second trimester. What happens is the blood volume starts to increase. It increases to the ratio of around 30 to 40%. This increase is more because of the increase in the plasma volume. If you see the plasma volume, it is increased by 40 to 50%. However, the red cell volume, it does not increase in proportionate to the plasma volume, but does increase 20 to 30%. So this gives you an idea that the plasma volume is expanding more in comparison to the increase in the red cell volume. So this gives you a dilutional picture, that is, it gives to the anemia of pregnancy that we see as the physiological anemia of pregnancy. I hope this is clear. You can see in this slide as well, where you can see that the highest rise is in the plasma volume, and red cell mass does increase, but not to the amount of extent to the increase in plasma volume. If these were to rise simultaneously, then there would have been no change in hemoglobin. But since the rise in plasma volume is disproportionately higher than the rise in the red cell mass, we expect the drop in the hematocrit beginning at the end of the first trimester or the beginning of the second trimester. So what are the predisposing factors that lead to the development of iron deficiency anemia, which is so much prevalent in our part of the world? So it is very common. There are increased demands of iron, folic acid, and B12 because of increased consumption or need by the fetus, as well as the mother's expanded blood volume. There is diminished intake. If there is diminished intake, like if there is poor dietary habits, and because of excessive morning sickness or excessive vomiting, there is a poor absorption of the nutrients. This may also render the women more vulnerable to iron deficiency anemia. Another is distributed metabolism. If we see there is pregnancy induced depression of the bone marrow, which may lead to distributed metabolism. So there is effective hemoglobin becomes less. So there may be different chronic infections or chronic disease that may also lead to suppression of the reticuloendothelial system, like malaria, which is far more common in our part of the world, and even infections like asymptomatic bacteriuria. That is why we do screening, routine screening at the first antenatal visits to exclude bacteriuria, as it is one of the predisposing factors of anemia, and also it leads to other consequences for both the mother and the fetus. Other medical problems like hemorrhoids or piles are also more common in pregnant women because of the effect of progesterone. As you know, there is relaxation of the lower esophageal sphincter, which leads to more reflux. Okay, that may also lead to gastritis and ineffective absorption. Another common features that we can see is worm infestation because of faulty dietary habits or poor hygiene. Another predisposing factor is pre-pregnant state of iron reserve. In our context, if we see, even in non-pregnant females, the baseline hemoglobin is far lower than required because of poor nutrition, as well as most women, they do not seek advice if they have heavy bleeding during menses, and hence their loss is more during menses, the blood loss. It renders them more vulnerable to anemia during pregnancy. Likewise, pregnancy factors like multiple pregnancy where the demands are increased, frequent childbirth when the woman's health has not been restored and again subjected to the stress of pregnancy, and even menstrual disorders. These are other predisposing factors for the development of anemia in pregnancy. If we see what is the demand of iron throughout pregnancy, if we see it, the extra iron, total iron extra required is around 800 to 1000 milligrams, and around half of it is required for the increase in the red cell mass. Around 350 grams is required for the fetus and the placenta, and 250 milligrams we estimate the loss that may happen during the process of childbirth or basal losses. So this is the total requirement is around 800 to 1000 milligrams. So if we see this total 800 to 1000 milligrams, it is required more towards the second and the third trimester, because there is more of the organs are to be perfused. So in the early pregnancy, iron demands may be as little as 2.5 milligrams per day, while it increases in the second trimester around 5.5 and up to 7 in the third trimester. So we categorized anemia according to the level of hemoglobin previously. Now, how do we classify anemia? There are various methods of classification. One is the physiological anemia of pregnancy, which I briefly mentioned earlier because of the drop in hematocrit in the second trimester, which is physiological. And another is pathological anemia. Pathological anemia you have read in your pathologies in your first and second year sessions. Basically, they may be nutritional owing to iron deficiency anemia, which accounts for nearly 75% of the cases. And there are even causes like folic acid and vitamin B12 deficiency, more in vegetarians. And another cause may be hemorrhagic disease. There may be hemorrhage because of antepartum causes like placenta previa and abruptio, or there may be chronic bleeding or chronic loss from piles or hookworm infestation. Our females who are working in the fields who are barefooted can contract hookworm and may be having chronic blood loss due to that infestation. And there are other causes like hereditary causes, as you well may know, sickle cell anemia, thalassemia. These are prevalent in some of the local communities in the Tarai region, and even other hemoglobinopathies. And radiation or drug-induced bone marrow suppression may also lead to pathological anemia. And another is the anemia of chronic diseases like tuberculosis and even other infections like malaria and Kala-Azar. So I briefly mentioned about the physiological anemia of pregnancy. What it is it is the drop in hemoglobin in the second trimester. Okay, in the second half, if the hemoglobin is 10 gram% and the RBC is 3.2 million per mm³ with normal morphology of red blood cells with central pallor, then that we classify as physiological anemia of pregnancy. Remind you, if it is pathological, the peripheral smear picture is totally altered with the hemoglobin dropping far beyond 10 gram per deciliter. So if we see about the metabolism of iron, it is absorbed in the ferrous form in the gastric because of the gastric acid. The ferric form is reduced to the ferrous form in the stomach, and it is absorbed from the duodenum where it is bound to transferrin, and transferrin is absorbed through pinocytosis in the intestinal mucosa. And then it is carried over to places where required, like for erythropoiesis in the reticuloendothelial system, for storage in the liver in the form of ferritin, and there may be basal losses in other forms, that is by desquamation of the intestinal epithelium. So if you see here, the Western diet contains about 15 milligrams of iron per day, while the recommended dietary allowance for pregnancy is twice of that. And only 10% of the dietary iron is absorbed. So hence there is requirement of extra iron. Even if we give double the diet that the Western diet they contains, only 10% of it is absorbed. Hence we give routine supplementation with iron, therapeutic iron capsules. So we saw earlier that the demand of iron increases in pregnancy from the first to the third trimester. If you remember this slide, it is around 2.5 here, 5.5 in the second trimester, and about 7. So it is tripled in the third trimester, peaking after 30 weeks. So what are the things that facilitate the absorption of iron, and what are the things that inhibit the absorption of iron? This is important while counseling patients during intake of iron, they should not be taking things that inhibit their absorption. And one of the common mistakes that they do is they take their iron and calcium tablets together. But as you see here, calcium inhibits the absorption of iron, and hence patients may be iron deficient despite taking iron regularly. Other things that inhibit the absorption of iron are phytates that are present in cereals, even tannins in tea. And what facilitates their absorption, can we advise them to take iron with is juices that may contain vitamin C, and even gastric acidity also increases the absorption of iron. So the absorption of iron is only about 5 to 10%, and even less in pure vegetarian diet. Additional iron daily demand in early pregnancy is, as we said, 2.5 milligrams per day, and in the third trimester it is around 7 milligrams per day. So the daily supplement of around 40 to 60 milligrams of elemental iron is required during pregnancy. So this is the number that you must remember, that the elemental iron requirement during pregnancy per day is 40 to 60 milligrams. And folic acid requirement is also 400 to 600 micrograms per day. So what are the clinical features that tell us that the patient is having anemia during pregnancy? They may complain of excessive weakness, easy fatigability, or even laziness. They may be irritable. They may think that their headache and dizziness is just because of hormonal imbalance, while it may be due to anemia. Sometimes if it is severe enough, they may have syncopal attacks. They may complain of palpitation, shortness of breath, which is similar to patients presenting with heart disease. They may have swelling of the bilateral lower limbs or generalized body swelling called anasarca. And some people, they may even have anorexia, intermittent claudication, symptoms of angina. And one of the unique things about iron deficiency anemia is pica, or craving for non-food substance like clay. Okay. These are the clinical symptoms that the patient may present to you that may be dismissed as non-specific features. Okay, so we need to be very careful even with these non-specific symptoms. So what are the signs? If you see here, the first sign that we see in the eyes, in the lower conjunctiva, lower palpebral conjunctiva, we see pallor. Okay, this is one of the signs of anemia. This picture here showing the inflamed tongue, this is known as glossitis. Patients with anemia may have glossitis. There may be signs in the nails, that is koilonychia or spoon-shaped nails may be present. And this is angular stomatitis. In the angle of the mouth, there is inflammation, and here throughout the perioral area, there is cheilitis. So these may be the signs that are subtle evidence of anemia that we must look for during our clinical examination. Other signs is there may be edema, there may be generalized anasarca as well. And if you see the pulse, there may be tachycardia with a bounding volume. Okay, and during the cardiovascular examination, we may find a soft ejection systolic murmur at the mitral area, which is known as the hemic murmur. And sometimes if the patient is in severe failure, even in cardiac failure, then we may be able to listen to basal creps in the lungs. Also, for other causes of anemia, we may find there may be jaundice if there is hemolytic anemia, hemolytic disorders. There may be purpura or hepatosplenomegaly, especially hepatosplenomegaly may be present if there is a sickle cell anemia, even in infections like malaria, Kala-Azar, chronic disease infections, there may be hepatosplenomegaly. So you do not render see that all iron deficiency, all anemia in pregnancy is iron deficiency, but you have to exclude other causes as well, even if they are less common. So why do we need to know what does it affect on the pregnancy as a whole? The woman has been living with anemia for a long time, all her life till now. So what effect does it have on pregnancy that we are more concerned about? In other words, in antepartum period, because of anemia, patients may be susceptible to more recurrent infections. They may succumb to congestive cardiac failure in the antepartum or even in the intrapartum, as well as in the postpartum period. And if we see here, around 30% of the patients with anemia in pregnancy coexist with conditions of preeclampsia and preterm labor. Okay? And postpartum problems, if you see in anemia, it may lead to postpartum hemorrhage. Anemia itself may be a cause of postpartum hemorrhage, and more so because these women who have low reserves of hemoglobin cannot withstand even small amounts of blood loss, and they may collapse easily. And they may also be presence of subinvoluted uterus, and they may have venous thrombosis, they may have problems in lactation, puerperal sepsis, okay? And even if they have undergone cesarean section, there may be problems of delayed wound healing and wound infection. So these are the effects of anemia on pregnancy. So does it affect the fetus? If we see here, it does affect the fetus. In the first trimester, if the woman is severely anemic, then there may be fetal loss, which we tell as abortion, and the fetus may not be able to grow properly, that we say as intrauterine growth restriction. They may have prematurity and low birth weight, and in the long term, they may have problems of delayed cognitive function, decreased iron stores even in the fetus, fetal anemia. Okay, and there may sometimes, rarely, it may lead to intrauterine fetal death and increased perinatal mortality and morbidity. So we can see that it affects both the mother as well as the fetus. So how do we approach a case if we encounter a patient who has anemia? Age is very important, because if we see teenage pregnancy is quite common in our part of the world, when females have not restored their full body function, and they may have less iron stores, and they are already succumbed to pregnancy. Parity is important, as we see greater the parity, greater the problems of anemia, because they have not been able to restore their iron status. And again, multiple pregnancies at short intervals as one of the most important risk factors. Address and race, as we said, that sickle cell anemia and thalassemia, they are more prevalent in some parts of the country, and it is also important if these are the areas where there is more prevalence of infections like malaria. We should ask about dietary habits, food habits. If it is vegetarian diet, they are more liable to have megaloblastic anemia. Okay, and what are the diets that they are taking? If it is sufficient enough, it will also give us an idea about the management protocols. If there is any chronic bleeding, if they are having upper GI blood loss, they may have hematochezia, worm infestation, and even we have to ask about the prevalence of malaria in their area. So as I told you, in the clinical examination, from head to toe examination, we can see pallor in the conjunctiva. We may see in the facial area angular cheilitis, glossitis, stomatitis. In the nails, there may be koilonychia. If you see, there may be edema if the anemia is severe enough. And on auscultation, there may be a hemic murmur, and basal crepes may be present on lung fields. And also, there may be presence of a bounding pulse with tachycardia. So this summarizes our clinical examination. So how do we investigate? Why do we need to investigate is basically, we have to know the degree or severity of anemia. We have to detect the type of anemia and know about the cause of anemia. All these things are important from the management point of view. So we need investigations basically for these three purposes. To know the degree of or severity, as we told earlier, by hemoglobin we have classified it as mild, moderate, severe, and very severe. Red cell count and packed cell volume also reflect hemoglobin. Okay, and besides that, again, I'm reviewing here the physiological anemia of pregnancy, especially in the second trimester. If the hemoglobin is up to 10 gram per deciliter with peripheral smears showing normal morphology of red blood cells, it is just physiological anemia of pregnancy and may not need treatment. To know the type of anemia, a very important investigation that you must not miss is peripheral blood smear. Okay, before transfusing, before doing any other investigations, this is a very simple procedure that saves a lot of our time and effort. So if the picture is normocytic, normochromic, or it is microcytic, hypochromic, or macrocytic hypochromic anemia, especially if when we're dealing with iron deficiency anemia, as you all know, it is microcytic and hypochromic. Other types of pictures may be seen, especially if you can see in iron deficiency, the red blood cells are small in size, meaning microcytic, hypochromic, meaning pale, anisocytosis, there is variation in the size of the red blood cells, poikilocytosis, with or without the presence of target cells. And sometimes in peripheral blood smear, you may be lucky enough to identify the cause as anemia if you see malarial parasites themselves. Sometimes the blood smear may show no or low counts, showing that aplastic anemia may be a cause of the anemia. Sometimes you may see sickled cells, like here, there may be sickling of cells. There may be toxic granules, if you see here, and abnormal blast cells, as seen in leukemia, and there may be target cells you can see in thalassemia. So the blood smear may tell us a detailed picture about the type of anemia, and hence direct our management towards the cause. So in iron deficiency anemia, because we're dealing with it because it constitutes the major bulk, you can see that it is microcytic, meaning the mean corpuscular volume is decreased, the mean hemoglobin is also decreased, and the MCHC is also decreased. The peripheral blood film shows microcytic hypochromic anemia. There is decrease in transferrin saturation, and the only increase is in the total iron binding capacity. Because the stores are less, the binding capacity is increased. So this is the picture of iron deficiency anemia if we do an iron profile. Other examinations, other investigations that we send are urine examination that may show microscopic hematuria or red blood cells, or even asymptomatic bacteria. It may be a cause or predisposing factor for anemia. Stool examination we do to rule out occult blood. If there is chronic GI blood loss or upper GI loss, it may show occult blood positive. And there may be chest X-ray, peripheral smear showing malarial parasite, and there may be renal disease. So we do blood urea nitrogen and serum creatinine. So prophylaxis against iron deficiency anemia, we know about the dietary habits. It is more common in vegetarians. So even in vegetarians, we can advise for green leafy vegetables, cereals, sprouted pulses, fruits, jaggery, and dates, and advise for cooking in iron vessels. Avoid frequent pregnancies, and there are also salt fortification programs in other countries. Prophylactic treatment of helminthic infections is done in all pregnancies with single dose of albendazole 400 milligrams or mebendazole 400 milligrams BD for 3 days in the second trimester. And we routinely practice supplemental iron therapy starting from the second trimester with 60 milligrams of elemental iron. Your iron therapy will be dealt in the next class. The national protocol, this is the national protocol of giving 60 milligrams of iron and 400 micrograms of folic acid. So blood transfusion is reserved for severe cases if it is detected in the first time after 36 weeks, or there is blood loss due to acute causes like antepartum hemorrhage and postpartum hemorrhage, or the patient is not responding to oral or parenteral iron therapy, or even if the patient is severely anemic and symptomatic, with dyspnea, heart failure, irrespective of the gestational age, we may have to transfuse blood. And while transfusing blood, it must be properly typed, cross-matched, it must be compatible, seronegative. Packed cells are preferred over whole blood to avoid overperfusion, okay, with all necessary precautions for managing transfusion reactions. And blood transfusion, remember, it may trigger preterm labor and pulmonary edema, so we must be very cautious while transfusing blood. So management during labor should always be supervised as it is a high-risk pregnancy. Early counseling and consent is to be done, and we have to be ready with whole and packed cells which are properly typed and cross-matched. Patient is kept in a comfortable position, maybe propped up with intermittent oxygen. All necessary precautions to prevent infection like routine antibiotics may be in hand. And to tackle blood loss, all the oxytocin blood should be ready. Strict aseptic precautions are taken as they are at increased risk of infections, and minimal per-vaginal examinations. Prophylactic antibiotics can be given, and we do not give excess fluids. We avoid excessive fluids to avoid cardiac overload with maintenance of patent IV line. So in the second and third stage, the second stage is cut short by the use of forceps or ventouse, so that the mother does not have to apply more force, which may lead to cardiac failure. Active management of the third stage of labor is done as routinely with all oxytocins. Rectal misoprostol, this can be given after delivery of the fetus, as it is a pre-risk for developing PPH. So we may as well give prophylactic misoprostol as well. However, methergine is contraindicated. And as I told earlier, even small amount of blood loss may be tolerated very poorly in these patients. So we have to be very careful. And after the delivery, we may give IV furosemide to decrease the cardiac load. In the puerperium, early ambulation is encouraged to prevent thrombus complications. Hematinics or iron are continued for a further 3 to 6 months. We have to watch for subinvolution, signs of puerperal sepsis, heart failure, thromboembolism, and even lactation failure. We must counsel about proper diet. Spacing is very important, as well as contraceptive advice. Avoid pregnancy for at least 2 years in both normal as well as operative delivery. Lactational amenorrhea method may be used for the first 3 months. Then we can use barrier contraception, progesterone-only pills after 3 weeks. IUCD or even permanent sterilization may be counseled if the family is complete. So in summary, if we see, anemia is a global public health problem, and more so in developing countries like ours, where 75% of the women in the pregnancy are suffering from iron deficiency anemia. Prophylactic iron therapy with antihelmintic is given to all pregnant women under the national program. This anemia is an important cause of maternal and fetal morbidity and mortality, and hence must be identified early. You identify the problem, find out the cause with all relevant investigations, treat using good dietary advice, giving oral and parenteral iron, and blood transfusion as per indications. And remember, you should look for other causes of anemia too. Thank you. This concludes my session on anemia in pregnancy. If you have any questions, please do write in your chat box. And your prophylactic iron therapy and even parenteral iron, all will be dealt in another class, which is iron therapy in pregnancy.